Who is qualified to diagnose a tongue tie in a newborn?
So it's different. Scope of practice is going to be different in different states. Generally speaking, a doctor can diagnose, right? Or a dentist. A nurse, an RN, a lactation consultant, we cannot technically, unless we have an advanced practice. So unless I'm a nurse practitioner with an advanced practice degree, or, I'm a lactation consultant and I'm also a doctor, technically we cannot diagnose tongue ties. Now, what I will say is that the feeding specialist is usually the one who is seeing them, because we are the one, it's all about feeding function. From the moment that life-changing stick revealed its verdict, our journey began. Suddenly, we were entrusted with the monumental task of motherhood. But amidst the joy, fear of the unknown sets in. How do we navigate this uncharted territory? With countless voices ready to guide us, it's easy to feel lost. Hey, I'm Hillary. I'm the founder of Baby Settler. I'm also a registered nurse and mom of 4. I hope to be your trusted friend who helps guide you through the maze of early motherhood. I'm grounded in medical expertise with a sprinkle of crunchiness, and I'm here to debunk myths and unravel truths. With a dash of type A energy, I promise to leave no stone unturned. Joining me on this adventure is my non-medical older sister, a future mom herself. Together, we'll get into the heart of early motherhood, asking the tough questions and seeking honest answers. So grab a cup of coffee, steal a moment for yourself, and let's dive into the adventure of early momming together.
Welcome back, mamas. We have an awesome conversation to share with you today.
I'm Hillary, your host, the CEO and founder of Baby Settler, and I'm also a mom of 4.
And I'm Erica, Hillary's big sister, a future mom, and our listeners' non-medical type A ambassador each week. Well, this week we have a special episode. We are going to share some information, actually some special information about tongue ties. So we're going to jump right in it today and really talk about what is a tongue tie and why do we care to identify these in newborns. So Hillary, you start and tell us why you thought it was important information to share with our listeners.
Tongue ties is a very timely topic. I know we're going to reference some news articles that have been kind of put out in the last year, but I think it's important because it is relevant today. A lot of moms and dads that I see in private practice, the first time I see them, I've never met them before. They walk into my office and one of the questions they have is, does my baby have a tongue tie? And I would say even 2 to 3 years ago, I wasn't getting asked that question nearly as frequently as I am now. And so I feel like because it's in the news, because it's on social media, everybody is talking about tongue ties. Feeding specialists, occupational therapists, physical therapists, lactation consultants, tongue ties are getting blamed for a lot of problems. It's just a very hot topic. It's started on social media, I feel like, and it can be one of those polarizing topics. I feel like, and we can get into this a little bit more about my views and kind of what I think about tongue ties, but I feel like a lot of pediatricians and pediatric providers are annoyed by the suggestion that all these babies have tongue ties. And, there are lactation consultants and feeding specialists that basically want to blame everything on tongue ties. And there has been a lot less critical thinking when it comes to trying to figure out what's going on with the baby. And like I said, just a lot of things are getting blamed on tongue ties, which some of the things are related to tongue ties, but it's become it's a big business. Like, what was that title we were talking about? That was at the New York Times. Like, what's the article what was their headline title?
We'll jump in because I think you bring this up a good point. This is in recent headlines. Washington Post in July this year, it was more informational, but it was what are tongue ties and how can they be fixed? New York Times, in the last year, I think December of last year, with an aggressive title, Inside the Booming Business of Cutting Babies' Tongues. I saw that and I was like, wow, that is a really aggressive stance on tongue ties. And then Parents Magazine put out an article last month that was called "Is Tongue Tie Being Over Treated?" AAP thinks so, which the AAP is the American Academy of Pediatrics. Yeah. So there's a lot of current news articles that literally I Googled tongue ties and newborns, and those were the top three of the top 5 articles that came up. And it surprised me that the majority of the articles that were being listed were kind of the, they were on the negative, like aggressive scale.
Yeah, I think that probably the American Academy of Pediatrics is trying to get ahead of, they're trying to take a stance on it because it's been a runaway narrative for the last couple of years.
Well, because New York Times has said there's a booming business of cutting babies' tongues.
Right. Yeah.
So it's almost like a direct response.
Right.
To that.
Exactly. I will say, so let me back up and give you kind of a frame of reference. So my oldest will be 13 in November of this year. My youngest just turned 2 in July. All 4 of my kids have had tongue ties. My first child was undiagnosed tongue tie. He was mostly fine. Breastfeeding did not go well with him. He did totally fine with bottles. He did fine starting solids. He did have, he was in speech therapy for 4K through 2nd grade. Was that related to his tongue tie? Maybe. I don't know. My second child had a tongue tie, again, undiagnosed. He will be 9 in November. Didn't really know even anything about tongue ties. We had some breastfeeding challenges early on, but we were able to he was able to compensate and we got through them. He had major issues starting solids with texture. So he was 14 months old and he couldn't even tolerate hardly any purees. Was that related to his tongue tie? Yeah, probably. His tongue was probably not super mobile and he had a hard time with textures and function of his tongue. My third child, who just turned 6 this summer, she did get her tongue tie released by an ENT doctor in her 1st or 2nd week of life. Did I do everything I should have done to really support her? No. Did she actually need a tongue tie release? I don't know. Maybe, maybe not. But I didn't have all the information that I do now that would have helped me make a better decision there. She went on to breastfeed. She was my most successful breastfeeding journey. If you ask any other, lactation consultant, I think we've talked about it on this episode, like what is successful breastfeeding, and it's very specific to each mom and baby and what their goals are. But, just saying like, okay, she did the most direct breastfeeding. She was almost exclusively breastfed, right? She only got bottles when I was away at work. So, and then my youngest, who is 2, approached tongue ties completely differently with him than I did with my other kids, mostly because I didn't know about tongue ties for the first 2. But I spent my whole maternity leave, because he was having such major feeding challenges. I basically spent my whole 12 weeks postpartum looking at tongue ties and alternative therapies to help with tongue ties and oral tension, and change the way that I practice medicine based on what I learned and my experience with him. And then also like really looking at the research and really looking at what are all of our options when we have a baby with oral restrictions. And by oral restriction, that can be their frenulum is tight and they have that, they don't have the mobility that they need, or it could just be that there's tension in their mouth and they're not able to move their tongue because there's a lot of tension in their mouth. So, the New York Times article, I read it. I think when I don't remember exactly what it said, but when I read it, my thought was, okay, I get where they're coming from. And I agree. Everyone wants to help moms and babies, right? Mm-hmm. It's big business, whether you're selling a product or whether you're selling yourself or your service or whatever. It's fun. It is like it's really fun to work with moms and babies, and everyone wants to do it. And so everyone's going to try to find a way to do it. And I think that's what's happened in this space. You know, the AAP in that article just telling what can happen. And I get into this more in this episode that you're going to hear in a second. I kind of get into the nuance of this. But what can happen is there are a lot of things that can be symptoms of an oral restriction, and just telling a parent, hey, listen, this is going to get better at 4 to 6 months right now is really hard. You just have to wait until your baby's 4 to 6 months old. I don't think that's fair to parents. It's just because 4 to 6 months doesn't seem like that long. But when you have a baby that's having major feeding challenges, or is having reflux, or is crying, 20 hours of the day, is not sleeping, and their baby is 6 weeks old, to tell them, hey, this is just what it is, and you're just gonna have to wait till they're 6 months old. That's not really a good answer. It's just not. Yeah. And I think that you have to be willing to look at alternative, more conservative, maybe even holistic therapies like craniosacral fascial therapy from a licensed, which is body work from a licensed, so like a physical therapist or occupational therapist who knows how to move the body. Using that, there are some studies that are starting to come out with that. There's not a ton of them, but doing something like that, doing oral motor therapy, things like that are non-invasive, that are very low risk to your baby, are not as high risk as doing a tongue tie release. That needs to be part of the conversation with pediatricians and parents, and it's not. And so I think that is, when I look at all of these articles, it's just like, okay, well, we think there's too many tongue ties going on, but hey, we're not going to give you any alternative. This is just what it is. And you're just going to have to wait until your baby is 6 months old. And that's just it's not a good solution.
Yeah, no, that's great information. Who is qualified to diagnose a tongue tie in a newborn?
So it's different. Scope of practice is going to be different in different states. Generally speaking, a doctor can diagnose, right? Or a dentist. A nurse, an RN, a lactation consultant, we cannot technically, unless we have an advanced practice. So unless I'm a nurse practitioner with an advanced practice degree, or, I'm a lactation consultant and I'm also a doctor, technically we cannot diagnose tongue ties. Now, what I will say is that the feeding specialist is usually the one who is seeing them, because we are the one, it's all about feeding function. So you shouldn't diagnose a tongue tie based on how it looks, because you could have a baby that looks like they have a severe tongue tie, but their feeding function is there. They're not having any symptoms. Mom is not having any symptoms. We're not, technically, if they have full mobility of their tongue and they're a functional feeder, it's not technically a tongue, it might be a visible frenulum, but it's not technically a tongue tie. So your pediatrician, I think they're the one, they can definitely diagnose tongue ties, but I wouldn't say that for the general pediatrician, that's going to be their expertise. I would say it's going to be a pediatric dentist or an ENT doctor. But even then, unless those two providers are watching you feed your baby, whether you're breastfeeding or bottle feeding, and actually going in there and feeling their suck and seeing if their tongue will elevate, like it takes me at least 30 minutes to an hour to do an assessment on a feeding assessment, and to really assess and give my opinion on whether or not the baby has an oral restriction. It's not a quick, let's suck on my finger and nope, I don't see a tongue tie. Your baby doesn't have a tongue tie. It's really not that simple.
So what I'm hearing is that just because it might look like there's a tongue tie, but you're having functional feedings and everything's going well in that department, there may be no action needed. But there also may be the case where you're working with a feeding specialist and maybe the tongue tie has not been presented or brought up to you by a doctor or a medical provider. but it's still maybe something that you need to maybe explore a little bit. And it's not always the release of the tongue tie that is required. It could be some other form of therapy to work around it. That's what I'm hearing. Okay.
Yes. And the reason that's important is because for babies to sleep well, and you know me, I'm always coming back to the sleep. I'm always coming back to the sleep side of it. But for babies to be able to drop overnight feeds, they have to be efficient, effective feeders. They have to be able to take all their volume in their 12-hour day as they get bigger. So obviously a baby in the first 6 weeks is not dropping their overnight feeds. They're still feeding at least probably twice, but sometimes maybe once after 6 weeks, but somewhere between 1 to 3 times overnight in those first 6 to 12 weeks. But if they are not able to transfer a larger volume, whether they're breastfeeding or bottle feeding, if they're getting fatigued with feeding, they're not going to sleep well because they're not going to be able to sleep long periods of time because they're going to have a stopping point of how much they can take. Also, on the other side of that is if they are swallowing a lot of air because they aren't able to they aren't able to keep their tongue elevated and keep that seal on the bottle nipple or the breast nipple. If they are swallowing a bunch of air with feeding, it is going to show up as symptoms. It's going to show up as reflux. It's going to show up as really uncomfortable baby. Your baby is going to be really tense. And so those babies also do not sleep well. And so for me, I'm looking at it. I want to make sure that we're getting really good quality feeds so that we're setting your baby up to sleep well between feeds and then setting them up to eventually drop those nighttime feeds. And so I would say that there are lots of things you can do, but and this is what this episode that we're going to lead into, it's actually an excerpt out of my nighttime weaning guide. But I really I go into some case studies with some real life patients that I've seen. And I help you understand like how this all works together. And I also give you the Baby Settler clinical team's pathway for how we treat tongue ties. Like if we identify a baby with a tongue tie, here is what we do. Here is what our care plan looks like, because there are a lot of options out there. And you really do, at this point, with where we are on this topic, you have to be informed. You just have to be informed. You have to take the time to be informed about it, because you're not going to be able to make a good decision if you don't have some knowledge on this. Okay,
great. Well, I think that is a great introduction for what we're going to play. So it comes from the Baby Settler Nighttime Weaning Guide. If a listener wants more of that, where can they find that?
Yeah, they can go to
babysettler.com. Okay, great. All right. Well, before we get into the episode, let's hear a word from our sponsor, who is actually Baby Settler.
This podcast is brought to you by Baby Settler. Here's the deal. Most parents and healthcare professionals don't realize that 95% of the sleep puzzle in the first 6 to 12 months is feeding. Your baby needs to be able to take a quality, efficient, effective feed, whether they're breastfeeding or bottle feeding, to be able to drop nighttime feeds. There is a very uncomplicated strategy to this. In my ultimate guide to nighttime weaning, I walk you through it step by step. It's a guide for babies 0 to 12 months old, delivered through our custom Baby Settler app. Go to babysettler.com to find out more. You deserve to be the best parent you can be, and I truly believe that as parents, we need uninterrupted sleep to thrive.
All right. Well, without further ado, mamas, please enjoy the following information from Hillary's Nighttime Weaning Guide.
Okay, what are tongue ties? If you have no idea what a tongue tie is, you're not alone. Most people don't usually hear this term until they're knee deep in the newborn days and are likely experiencing some type of feeding difficulty. If you have a baby that is being pegged as refluxy or colicky and you start Googling, what can you do for this? Google will tell you your baby might have a tongue tie and send you down a road that has many differing opinions about how and why to treat tongue ties. While some old school pediatric providers might brush tongue ties off as a new thing, or they might say something like, I've been a pediatrician for 20 years and tongue ties aren't really a thing, I can tell you this simply isn't true. I want to start by reflecting on our own childhood. Have you ever heard that you were a fussy or colicky baby? I know I was. Did your mom tell you that her milk never came in? Did your mom even breastfeed? I'm going to guess that if she did, she probably struggled. There wasn't a lot of support for our moms when they were breastfeeding. A lot of the problems our moms faced in early infancy were probably related to tongue ties. Even back in 2010, when I had my first baby, his tongue tie went undiagnosed and I had no idea what a tongue tie was. Knowing what I know now, it was the reason we experienced complications. In the past, if things weren't going well with breastfeeding, the pediatric provider would likely recommend formula and toss it up to mom's low milk supply without really questioning why the mom and baby were having breastfeeding difficulties. Honestly, it's not the pediatrician's fault. We know that a collaborative care team approach is the secret ingredient to positive outcomes for breastfeeding. Pediatric providers need to know many things about babies from birth to 18 months to 18 years. But they only get to spend 20 minutes with you on a visit. We could really peel back the layers here and see that this is a major healthcare issue, but that's not what this video is about. Tongue ties have always been around, and as a society, we ask questions, we make hypotheses, and then we seek to prove or disprove them. We should always ask questions and seek to further our knowledge about how our body works. If you find that you're working with a healthcare professional who is no longer actively working to further their knowledge about topics related to their specialty, and they are practicing or making clinical judgment decisions based on information they learned a decade ago, run the other way. Earlier, I mentioned that I noticed my fourth baby had a tongue tie as soon as he opened his mouth, right after birth. Obviously, this was easy for me to identify because this is my specialty. But how can you know if your baby has a tongue tie? I want to start by talking about what exactly a tongue tie is. A tongue tie is a tight frenulum, or tight frenulum is when the mid-tongue, the middle of the tongue, so if you visualize the middle of the tongue, cannot elevate to the hard palate. The tongue should really be able to move out past the lower gum line. When it cannot, this is referred to as an anterior tongue tie. This is the type of tongue tie that is obvious to pretty much anyone who knows anything about babies. When a baby is crying, you will notice the tongue will stay tied to the floor of their mouth. The tongue also needs to be able to lateralize. So that means it needs to move side to side. And then finally, the tongue needs to be able to elevate or lift away from the floor of the mouth. So to recap, the tongue needs to move up, it needs to move out, and it needs to move side to side. Now, a posterior tie is a little bit harder to identify. In order to diagnose or really dismiss a posterior tongue tie, the evaluator needs to elevate the mid-tongue. You cannot diagnose a tongue tie visually. You have to feel what the tongue is able to do. You really want to see is there a restriction when you elevate the tongue? That is the question that needs to be answered. Some medical professionals would argue that all tongue ties need to be released surgically. I personally do not agree with this recommendation, and I want to explain why. It's all about function. The questions that matter here are really, how is the feeding quality? Is this baby an efficient, effective feeder? Is the mom or baby having any symptoms? We're going to talk about these symptoms in a minute. But it's important that you understand that a baby being an efficient, effective feeder and how quality feedings really promote nighttime sleep. So here's an example. If you have two babies with the same tongue tie, graded on a scale, but one baby has full mobility of their tongue, is an efficient, effective feeder, and neither the mom or the baby are having any symptoms, why in the world would you mess with that? Right? So now this scenario it's rare. I would say that it's more rare, but I have seen it. The most important thing in this situation is to make sure your baby is really being evaluated by an experienced feeding specialist who has physically assessed your baby's mouth, taken a full history and lists out any symptoms you or your baby are experiencing, and this is the most important part, and has watched an entire feeding from start to finish. If this specialist can say, yes, your baby has full function and mobility despite the frenulum appearing tight, then there is really no need to do anything else. All right, I want to pause here and let's talk more about tension. I can usually spot a tense baby as soon as I lay eyes on him. He's either balled up with his legs and arms pulled toward his belly into a C shape, or he is stiff as a board. I hope that in the very near future, craniosacral fascial therapy, or also known as bodywork, will be offered to every newborn everywhere in the hospital, because birth is a traumatic event, even when it isn't. 3 of my 4 babies were unmedicated vaginal deliveries, but all of my babies had tension in their bodies that I could literally feel in their mouths. Working in the hospital as a lactation consultant, I saw this every time I'd round on patients. I'd go into my patient's room to help, and the first thing the mom would say to me is, "I can't get my baby to open her mouth." Or, "This feels so pinchy." A lot of times it's the tension. I want you to do yourself a favor. I want you to Google, find a Gillespie-trained infant body worker near me. And I want you to book an appointment for your newborn ASAP. I want you to budget for this. I want you to make it a priority. And especially if your baby has a tongue tie, this is your first step. Do not collect $200. Do not pass go. We are not going to the next step until you do this. So why? Why is that important? That is a great question. All right, here are the 2 reasons. First, tension can mask a tongue tie, and sometimes tension looks like a tongue tie. Second, if your baby has mouth tension that's unresolved prior to release of a tight frenulum, there's a very high risk for reattachment and or an incomplete release. Your baby's mouth is so small. Add tension to the scenario, and it's very difficult for a release provider to get in there and do a really good release. Your baby needs to be prepped for release when a release is needed, and that includes reducing tension in the mouth and jaw. I have seen so many babies go on to not need a release after body work. Maybe it looked like the frenulum was holding their tongue down, but after body work, the tension improved and the baby was able to elevate his tongue. Let me remind you, it is all about function. Sometimes tension is what's keeping the tongue from functioning the way it should. Sometimes it's the structure or the tie that's preventing the tongue from functioning the way it should. And if you get rid of the tension and the tongue is still tied, then you can feel really confident moving forward with a release. I'm going to share a little bit more about the baby settler pathway to oral restrictions that you can use as a guide. And this is kind of what we use in private practice with our patients. But before we get there, I want to talk about some of the symptoms of a tongue tie. Okay, so what are the symptoms of a tongue tie? I'm going to tell you about the red flags, but I want to emphasize that it's really important to work with a lactation consultant or feeding specialist if your baby is having any feeding related symptoms. This list is not all encompassing. Trust your gut. If you feel like there's a problem, work with a feeding specialist. Okay, so one symptom is low milk supply. The tongue is the motor of the latch. If a baby's tongue is not elevated to keep mom's nipple attached to the roof of the baby's mouth, so kind of think of it like a vacuum, and stretch the nipple to the soft palate, then milk is not being expressed as effectively as it should. For example, imagine that you're drinking through a straw. You clamp the straw between your tongue and your hard palate to reduce the diameter of the straw. When you suck, you're only going to get about half of what you'd get if the straw's full diameter was open for sucking. It's the same thing with a latch. And then talking about milk supply is all about supply and demand. If the milk isn't being demanded, the supply isn't going to increase to meet your baby's needs. An ineffective latch will lead to milk supply issues for many women. Nipple trauma, compressed, cracked, blistered nipples. This is all usually present in scenarios like this. Another symptom would be like a refluxy or gassy baby. If your baby is experiencing reflux symptoms, your first step is to ensure your technique for feeding isn't the issue. I'll talk about this a little bit more when we talk about it. You can Google in the app, like look in the app, not Google in the app. You can look in the app for searching pace bottle feeding or reflux, and you'll find a lot more information. But here I just want to mention that a tongue tie, lip tie, or oral tension can be the root cause of reflux symptoms. If your baby doesn't have a good seal on the breast or the bottle, she's swallowing air with her milk. And if her tongue can't elevate to keep the connection between the nipple, either breast or bottle nipple, when she swallows, then she's swallowing air, and this can lead to a really uncomfortable baby. Okay, the next one is long feeding sessions. When I'm helping a mom or baby with feeding, one of my first questions is, how long does it take your baby to feed? Anything over 30 minutes is a red flag. Long feeding sessions are a sign that your baby isn't an efficient feeder. If the tongue is working like it should, feeding efficiency shouldn't be an issue. Now, there are other factors in the early days that can contribute to long feeding sessions. However, after the first 2 weeks, a baby should be able to take a full feeding volume based on the baby's weight within about 30 minutes, whether at the breast or with the bottle. I could get really technical here, but it's really beyond this video. So I'm just going to leave it at this. If your baby is taking more than 30 minutes to feed, you need to go see a feeding specialist for an evaluation. Okay, another sign is choking events with feeding. So during the first 2 weeks, babies sometimes have a hard time with coordinating the suck, swallow, breathe rhythm, and they can choke. However, this should not happen with every feed, and it really should happen less frequency, and it should go away after the first 2 weeks. When a baby has an oral restriction, like a tongue tie or tension in their mouth, they might have a hard time with coordination, which often shows up as an event with feeding, and these events can lead to reflux and an uncomfortable baby. Sometimes babies will stop feeding after the event, even if they're not full, because it was stressful. We don't want babies associating stress with feeding. All right, sleep issues. Well, here we are all about the feeding and sleep connection. You cannot address sleep issues without first looking at feeding. Oral restrictions can lead to interrupted sleep for many reasons. Your baby might not be able to take more than 2 to 3 ounces at a time due to inefficiency of a feeding and fatigue. If your baby is uncoordinated with feeding, she might be really uncomfortable, and so sleep is interrupted. These are just 2 of the most common reasons why sleep might be interrupted. If your baby is experiencing sleep interruptions or isn't sleeping well, I encourage you to first look at feeding. Ensure your baby is getting quality, efficient feeds. Okay, I want to talk about 2 real-life examples of how tongue ties affect moms and babies. And we see these scenarios all the time in private practice. All right, so I'm going to tell you a story. I first started working with Natalie when she was about 5 weeks postpartum. Her son, Henry, was a big boy. He was about 13 pounds. Natalie was feeling overwhelmed because Henry wouldn't let her put him down. She was holding him all day long and co-sleeping at night so she could actually get some sleep. I never thought I'd be that mom, but I don't know what to do. He won't sleep unless I'm holding him. Why won't he sleep in his bassinet? Natalie went on to tell me that Henry was on medication for reflux, and her pediatrician suggested she remove dairy from her diet to make sure he didn't have a dairy allergy or intolerance. Her pediatrician really empathized with her, but said that everything looked normal and Henry was gaining great weight. But Natalie felt like something wasn't right. Henry always seemed uncomfortable. He was gassy and his body was so tense. She was worried that there was nothing else she could do to improve what she and Henry were experiencing. But then one of Natalie's friends told her about Baby Settler. And so she immediately booked an appointment with us in our Charleston location. And I had the privilege of working with Natalie and Henry. So as soon as Natalie walked into the room, I knew Henry had a tongue tie. He was asleep in the car seat and his mouth was hanging open. His lips were blistered on the top and bottom. We let him sleep for a few minutes while I asked Natalie more about what she was experiencing. She told me that Henry was feeding every 2 to 3 hours around the clock, but he would only feed for about 5 to 6 minutes on each side. Oftentimes he'd get choked on or let down. Natalie said he always made a clicking noise when he was feeding. She had tried pumping and giving him a bottle so she could have a break, but he refused to take a bottle. After every feed, he seemed uncomfortable and gassy. He spit up at times, but Natalie said that didn't really seem to bother him. Natalie didn't know it, but she was about to learn the why to her big question. Why won't he sleep in his bassinet? I want to pause here for a second. If you don't learn anything else from this video, I want you to learn this. Feeding affects sleep and sleep affects feeding, and it's really that simple. Okay, so why wouldn't Henry sleep in his bassinet? He wasn't getting quality feedings, and this was leading to a fussy, uncomfortable baby who wasn't able to sleep well because he was uncomfortable. Did he have reflux? Yes. Was medication the most effective treatment? No, absolutely not. Reflux medication for infants is not recommended in most cases. If your baby is having reflux symptoms, your first step is to have them evaluated by a feeding specialist and sign them up for body work. Okay, back to Henry. When I was working with a mom When I'm working with a mom and a baby, I like to see a feeding before I do an oral assessment. Why? Because I want to form an opinion about the baby's feeding function before I actually see what's going on inside their mouth. I don't want my feeding evaluation to be influenced by what I saw and what the baby's frenulum looks like. In this case, Henry was barely sucking at the breast. He latched and mom's milk literally sprayed into his mouth with her let down. He was latched on, but he wasn't actively participating in the transfer. He swallowed about 4 times, then paused, coughed, and unlatched about 2 minutes into the feed. He couldn't keep up with the letdown. There was a clicking sound intermittently during the feeding. Once the feed was over, I did a full oral assessment, including evaluation of his suck and oral motor function. I found that he had a posterior tongue tie and a lot of tension in his mouth. He had lip blisters because he was using his lips and cheeks to latch instead of his tongue. This had become his way to compensate for the restriction in his tongue. He was swallowing a lot of air because he wasn't keeping the seal between mom's nipple, his tongue, and his hard palate when he was feeding. He was gaining weight because mom had a very abundant milk supply and he was living off the letdown. He didn't have to work for the on-demand milk. In short, he was not getting quality feeds. This is why he wasn't sleeping well. Immediately, I gave Natalie some recommendations related to positioning and management of her milk supply to improve feeding. These were some Band-Aids until we could fix the root cause, which was the tongue. And then I explained what our care plan to get better sleep would include. And I'm going to tell you about it. It was oral motor therapy or suck training exercises. We started craniosacral fascial therapy or body work from a licensed physical therapist in our area. And then we did weekly evaluation of improvement based on our care plan. So about 3 weeks later, we agreed that Henry was ready for a release. The bodywork and oral therapy had improved things, but his tongue still would not elevate enough to function in an optimal way. Henry had a release with an experienced release provider, and he continued bodywork and oral function therapy for about 6 weeks after his release. I'm happy to report that Henry was sleeping through the night 11 plus hours in his crib by the time he was 12 weeks old, and there was no sleep training involved. We improved the quality of his feeding and the sleep quality followed. Okay. Low supply and tongue ties issues. This is what this example is about. So this is another mom that I worked with in real life. Okay. It was the first time I had met Emma and her baby, Charlie. I really began to feel super anxious as soon as I laid eyes on Charlie. I have changed the names here. This mom gave me permission to share her story. I'm just letting you know because this is a little bit, it's kind of a crazy story. So anyway, I want to let you know I changed the names. All right. So I said to Emma, nice to meet you. How's it going? What can I help you and Charlie with today? It was my icebreaker. Emma started crying immediately. She said that she was so worried that Charlie was not getting enough with breastfeeding. And I was worried too. The first thought when I saw that baby was, gosh, I am so worried about this baby. So Emma went on to say that she acts like she's always hungry. She said, I'm constantly feeding her. I even started giving her a bottle sometimes, but I'm not really pumping much milk. I saw on Instagram that it's normal for a breastfeeding mom to only pump 1 to 2 ounces, and breastfeeding babies don't need as much pumped milk as formula feeding babies. So I give her a 2-ounce bottle and she sucks it down. She acts like she's starving. So I wanted to come see you and make sure everything is going okay. I'm going to tell you that Charlie was scary skinny, like immediately thought in my mind, failure to thrive. I could literally see her bones. And I wondered if Emma saw what I was seeing. But sometimes when you're seeing your baby every day, it's hard to really have that objective vision. So I went ahead and I asked her, I said, when did you see your pediatrician last? And she said, we went for her 2-week checkup and she was back to her birth weight. So the pediatrician said she didn't need to see us again until Emma was 2 months old. So Emma was 7 weeks old, so 5 weeks ago. Sometimes, and I think I just said this, but I just want to drive this home. Sometimes when you see your baby every day, and especially when you're a first-time mom and you don't have experience with other babies, you don't see what someone else sees. So I said to Emma, okay, let's start with a weighted feed. I want you to show me what you and Charlie do at home. Then we'll weigh her and see how much she transferred at the breast. While Emma was feeding Charlie, I asked her a few more questions to gain some insight into what was going on. Emma said that Charlie was born on her due date. The first few days feeding were really painful. Charlie lost so much weight that her pediatrician had Emma supplement with formula until her milk came in. And then once her milk came in, she stopped supplementing. Charlie seemed to be doing okay for the first few weeks, but as she got older, the feeding times got longer and more frequent. Emma said a normal feeding took about 45 minutes. Charlie would feed and fall asleep, and then she would wake up about 20 minutes later and act like she was hungry again. In total, Charlie was eating about 12 to 13 times in a 24-hour window. Charlie finished her marathon feeding session and we weighed her to see how much milk she transferred. Immediately, I got that like stomach in my throat kind of feeling because 45 milliliters was all that she had transferred in 45 minutes. So that's about an ounce and a half. And then I asked Emma, would you say this is a typical feed for Charlie? And Emma said, actually, this is what a better feed looks like for her. Sometimes she isn't into it. So the next thing I did was an oral assessment. And yep, exactly what I expected. She has a posterior tongue tie. When I watched her feed, she was doing 3 to 5 sucks for every swallow, meaning there weren't very many swallows going on during that 45-minute feeding session. And that's why she only transferred an ounce and a half. With this scenario, you have to figure out if it's due to low milk supply or a baby's tongue not functioning optimally to be able to remove milk efficiently. In this case, it was both. I don't want to leave you hanging, but we could have a whole nother video on the next steps and kind of what our feeding care plan looked like going forward. But that's really another video. So the takeaway is this: a tongue tie can lead to mom having low milk supply because the baby isn't able to remove enough milk. Less removed milk equals low milk supply for most moms. In my clinical experience, undiagnosed and mismanaged oral restrictions are the leading reasons why moms discontinue breastfeeding sooner than they had planned. I hope you understand the importance of working with a lactation consultant after being discharged from the hospital. So in those first 2 weeks postpartum, even if you feel like everything is going well. And if you care about sleep, if it's a priority to you, you need to do everything in your power to ensure your baby is an efficient, effective feeder. If you feel like your baby isn't feeding well, I recommend finding a dream team in your area to help you. Okay, so what is a dream team? The dream team. You and your baby deserve this dream team. So I don't want you to settle for less. When it comes to tongue tie or really any feeding difficulties, you want to work with the experts. Unless your pediatric provider has a feeding specialty credential like an IBCLC, for example, and this is a really important part, and they are able to spend enough time to watch you do an entire feeding, at least 30 to 45 minutes, they probably aren't your experts when it comes to feeding difficulties. As a registered nurse, I had to seek out additional training and certifications to become a feeding specialist. I've also spent 10,000 plus hours working directly with moms and babies feeding. It takes a lot of time and dedication to learn what's needed to really support moms and babies with feeding difficulties. Even with my experience and credentials, I still value a collaborative care approach to optimize outcomes for my patients. Okay, so here's the dream team. An internationally board certified lactation consultant is your primary person. In my opinion, working with an IBCLC who is also a registered nurse is beyond valuable as opposed to working with an IBCLC who is not an RN. A nurse is looking at more than just feeding. We are looking at the big picture as it relates to maternal mental health and feeding. We know how to communicate in a therapeutic way. We actively listen and use professional judgment when making recommendations. We know how to work collaboratively with other healthcare professionals, and we are able to effectively educate you and meet you where you are. Okay, the other professionals listed here should have specialty certifications related to feeding. If they are also an IBCLC, that is a major bonus. These healthcare professionals would be used in addition to your primary IBCLC. Speech language pathologist who specializes in infant feeding. An occupational therapist who specializes in infant feeding and body work. A physical therapist, pediatric physical therapist who specializes in body work. A release provider. Now, let me tell you this, the skill level and technique here are more important than the tool used to provide the release. I'd choose the seasoned, skilled hands of a release provider over a fancy new tool. In a perfect world, all these providers would be under one roof. It is my dream, but in the real world, that's not going to be the scenario in most cases. Now, I want to tell you a little bit more about the baby settler pathway to treating oral restrictions and tensions. This is how we treat patients in our private practice. These are the recommended steps for evaluation, management, and possible procedural treatment of oral restrictions. Number 1, your baby needs to be assessed by an experienced provider for potential oral restrictions. At our practice, we attempt to do this with each in-person consult. However, there are times when this is not possible. So does the baby appear to have an oral restriction in the floor of the mouth? If yes, then you're going to continue down the pathway. Number 2, is mom experiencing any pain with feeding? Is the baby having any of the following issues? And this list, again, is not all inclusive. Slow weight gain, reflux, events with feedings or choking, bottle feeding difficulties, a tense baby, or a baby appears gassy or uncomfortable with or after feeds. If yes, we're going to go down the pathway. If no, and we think the baby has a tongue tie, but they're not having any symptoms, then I want to reassess that baby within 2 to 3 weeks to make sure no complications have appeared. Really important note here is if your baby is having trouble sleeping and it has been suggested your baby has an oral tie, this could be the root of the sleep issue. And we highly recommend scheduling a follow-up consult with a feeding specialist. All right, number 3, you're going to implement suck training and oral exercises. Number 4, if possible, you are going to implement that body work, the craniosacral fascial therapy. We have found this therapy to be highly beneficial for babies with oral restrictions, and we recommend this therapy prior to release. I want you to note, we really only recommend CFT under the care of an advanced licensed provider who understands how to move the body, like a physical therapist or occupational therapist. We in our private practice do not recommend body work be performed by a massage therapist or other non-PT OT provider. I'm not saying you shouldn't. I'm just telling you that that is our clinical judgment and recommendation. Number 5, you're going to follow up to see how implementation of the oral exercises and body work has improved feeding intention prior to being evaluated for a possible release provider. Because we want to make sure that if there is improvement, that we give your baby time to really see that full functional feeding improvement. If there is still a problem, then we are going to continue down the pathway. Number 6 would be to schedule an appointment to have your baby assessed by a release provider who has experience evaluating and treating babies for oral restrictions. I cannot drive home more the point that you want an experienced provider. You don't want the person that's closest to you. You don't want the person with the new fancy equipment. You want the most experienced provider you can find inside your baby's mouth. Okay, so did your baby have an oral restriction release? If yes, you're going to continue down the pathway. So here we're going to implement the wound care stretches and continue suck training and oral motor exercises. And you are going to follow up with your lactation consultant or feeding specialist within 3 to 5 days post-release. That is super important. Sometimes babies really do have complications with feeding post-release. So we want to make sure that we are going back to our primary person who is the driving person of our care team. Number 9, we are going to continue with body work and feeding specialists for continued evaluation for at least 6 weeks post-release. And the frequency of that follow-up can really depend on you and your baby and how things are going. I would say we usually see patients 3 to 5 days post-release, 2 weeks, and then usually between 3 to 4 weeks. And then again at that 6-week mark. I want to let you know there is also a download attached here that you can use to navigate oral restrictions. It was created by our speech language pathologist, Jessica Miller, who is also an IBCLC. She works on our care team in the Charleston, South Carolina area. And it really is just a great reference tool for you to print out, take notes, and just really kind of run through it. And if you're looking for that tangible piece of, okay, like, is my baby experiencing this? Do I think this is causing issues? It's a good place to start. So I recommend that you download that. But I know this is a lot of information. I hope it's been helpful. Key takeaway here is if there are any concerns, work with a feeding specialist in real life, in person, in your area. Thanks for listening to the Early Momming Podcast. Before you go, can I ask you a favor? If you enjoyed listening to this podcast and you're excited about what we'll be talking about in the future, please text your best friend this episode and tell her to give us a listen. And if you have time, do you mind going to leave us a review? Let us know what you liked. We are here to serve you. Plus, your reviews will make our podcast more findable for other moms to be able to join in on these candid conversations. Shout out to our sound guy, Kyle Moore, who makes it way easier to listen to us. And if you need to get in touch with us, send us an email at podcast@babysettler.com or send us a DM at Early Momming Podcast on Instagram. All right, we'll see you next time.